Hi, it's Dr. Mark Fulcher here. It's my pleasure to join you in this 11-11 lecture series. Today I'm joined by Dr. Jens Kleinefeld. Jens is based in Cologne, Germany. He is specialised in anaesthesia, emergency and intensive care medicine. Jens has a special interest in the prevention of sudden cardiac death in football and is an educator for both UEFA and FIFA. Welcome, Jens.
Thank you, Mark. Thank you for the invitation.
My pleasure. Now, I understand you're going to give us an update about how to manage a sudden cardiac arrest on the football field.
Yes, this is an important subject. We follow now, I think, since at least 12, 14 years. And it started with the death of Marc-Vivien Foé, who died during the semi-final in Lyon of the FIFA Confed Cup. And since then, we can see that we have a lot of dying football players till today.
And I understand that there may be an unofficial rate of one death per month in professional football.
Yes, we have, this is the average, what we can see, that we have sudden cardiac arrest at least once a month. Sudden cardiac arrest is the leading cause of sudden deaths in athletes, accounting for 75% of all deaths during exercise and sport in male athletes, African, Afro-Caribbean athletes. And interesting is that the basketball, American football and soccer athletes are in the highest risk group for sudden cardiac arrest. An Italian study also shows that the endurance athletes have a 1.5 higher risk to suffer a sudden cardiac arrest.
Mm-hmm. And when you look at it like this, it's pretty graphic, isn't it? So maybe not one of the more common things compared to other injuries that we see, but very significant.
Yeah, this is what we said before, once a month and sometimes even more. All this list on the slide now is really not this. We are just talking here about professional football players, but if you look at the sudden cardiac arrest with non-professional football players, of course, this list is much longer. Mm-hmm. In 2018, we already had some famous football players dying. A story from Italian Boban, the Croatian guy. And we also have very young players dying. Thomas Rodriguez, he was 18 years old. He died in France in March this year. Or Tyler Bennett is a 17-year-old teenager from Adelaide who suffered a sudden cardiac arrest. But as far as I know, he survived. And we also have it in other sports, like very famous was the cyclist Gollaerts, a Dutch guy who died at the age of 23, now in a race.
So clearly it's important that we all have an approach to manage this.
Yeah.
Okay.
When we talk about the causes, we actually don't know. When you look at it, of course, you have structural heart diseases like the hypertrophic cardiomyopathy, or the ARVD, which is arrhythmogenic right ventricular cardiomyopathy. And the ARVD is quite common. So this might be interesting to focus on it, because it's Dr. Hugh Calkins from the Johns Hopkins University. He published 2013 a paper about the ARVD in sports. And he found that people who have this genetic disease, this might lead in a sudden cardiac arrest when doing sports. And this is not that rare. 1 in 1,000 of the population have this genetic defect. So this might be one of the reasons why we have dead football players. Because if you look at it, the professional football players are tested in advance. They have the assessment, and we do echoes, we do ECGs, and all this stuff. But even if we do so, we see them dying on the pitch. So we have to focus on the things we cannot see with the normal procedures.
Okay.
And this is, of course, another part is the channelopathies, the Brugada and the long QT. But these are also things we normally see when we see the players the first time. When we do the ECG, normally a cardiologist can see it in the pre-assessment. So this might be a reason, but not I think it cannot explain why we still have these players. Very interesting for us is, of course, the myositis, which is increasingly identified as a cause of sudden cardiac arrest. Normally, this might happen if the players or if the athletes have an upper respiratory infection, which might lead to a myocarditis. And there's interesting also this year in the 2017, Professor Lund from Hamburg, he published in the cardiovascular imaging that 17% of healthy male triathletes have in an MRI, they could find myocardial fibrosis, which might be caused by myocarditis. So this might be very interesting. It was interesting because this study he published, he took 89 healthy triathletes, and just checked them. They had no problems. No, they were really healthy. And even then, he detected that nearly 20%, so 17%, had already scars in the myocard. And of course, this might cause then, if they do sport, this might cause then arrhythmogenic disorders. This might cause a sudden cardiac arrest. So this, I think, in my opinion, we have now two fields where we can focus on. The one is the genetic part, and the other is really the infection part.
Okay.
The other thing is, the coronary artery disease. This is actually, I don't believe in it. That we have it here when we talk about sudden cardiac arrest on the pitch, because normally these people who suffer from a coronary artery disease are in higher age, and it's not very common in the young athletes.
But I guess that's potentially an important topic when we're looking at more recreational footballers and older footballers.
Yeah, of course. No, of course. I talk now about this, of course, when we talk about the older generation, where we also have sudden cardiac arrest on the pitch. Of course, there we have to look at the coronary diseases, like the normal population. Well, because when we go out as an emergency doctor, we normally face people who has a myocard infarction or something like this, and then they suffer a sudden cardiac arrest. And of course, if the elder generation is still playing football, of course, this might be a cause.
Okay. So I guess one of the key things when you manage a sudden cardiac arrest is to be prepared.
Yeah, preparation is all. That's in all professions, we know. Everybody, you have to have a tool and you have to know your tool. And so the preparation, of course, when we talk about professional football, one preparation is that we have the players' medical checkup, what I said, to identify if we already have players in our squad who has some medical problems, heart problems, like a cardiomyopathy or like a hypertrophic cardiomyopathy, all this stuff. So this is the first of all we have to do. The second thing is we need to have an emergency action plan if really something happens on the pitch. Because when we talk about a sudden cardiac arrest, these are people we can treat very well, and we can save their lives, but we only can save the life if we have a plan. So first of all is we need to have an AED. The AED is a machine which we need for a successful sudden cardiac treatment of sudden cardiac arrest. So an AED, every team need to have an AED on the pitch during the training or the match. And sometimes because when we started this in Germany, some of the clubs, they said, yes, we have an AED. And I asked, where is it? Yeah, it's in the office of the manager because it's so expensive. And I said, then it's worth nothing. You need to have it on the pitch side or during the match on the pitch side, or you must have it very close and you know where it is. When I talk about an emergency action plan, this is essential to decrease the chance of a catastrophic outcome. And for this, we need personal training. This is very important. So everybody who is involved with the team should know how to use an AED, should know what to do, whom to call, and where, for example, the next help can be. So where's the next telephone, where's the AED, and all this stuff. So personal training is very important. And also it's very important that the training should take place on the site or the venue, because every site, every venue has its own specificities. So you should do it there so that everybody is familiar with the situation there. The immediate AED access, of course, is very important. And of course, if you talk about training, this training has to be repeated. A regular review and rehearsal, at least annually, is necessary.
So shall we talk about how we recognize a sudden cardiac arrest?
Yeah, this is, I think, the most difficult part of resuscitation. Because the resuscitation itself, I think everybody has already done the course. But the difficult part is to recognize a sudden cardiac arrest. And of course, there are guidelines. And these guidelines tell you, okay, if a player is not breathing normally or if a player is unresponsive, this might be a sudden cardiac arrest. But I would like to tell now to everybody, any athlete who collapses without obvious head trauma and is unresponsive on the field of play should be assumed to be in sudden cardiac arrest until proven otherwise. So this makes it much more easier. So if you see someone collapsing on the pitch with no body contact, assume this is a sudden cardiac arrest, and you just have to prove that it's not.
So I think
Sorry,
I think we've got an example of one of those non-contact collapses here. So the player in the center of the field obviously collapses with no one around him, as you talk about. So I guess that's what you're looking for.
Yeah, this is a typical thing, and of course it's a non-body contact collapse, and so this is typical for sudden cardiac arrest. When you, this is sometimes difficult to witness it. This is also might be during a match, because sometimes this happens on the side of the field where this moment is not the action. So even in case that you see someone laying on the ground and you haven't seen that there was a body contact or not, you have to think about this is a sudden cardiac arrest.
And you mentioned some other features like this, so the player may have their eyes open.
Yes, this is also what I said. It's very difficult if you have never seen it, because for the layman, it looks like that these people are still alive, because the players can have their eyes open, they can move, and And this is something where you normally say, because when we talk about someone is dead, then you think, okay, he's not moving, he's not doing anything. But at the beginning of the sudden cardiac arrest, you can have a rapid ventricular tachycardia. So this might be a minimal flow of blood in the oxygen. So there might be a minimal reaction of the players. So they can still move, they can have their eyes open, and they also might to appear that the player is breathing. This is not a normal breathing. Why? That's also it's written in the recommendation or in the guidelines. Is he breathing normal or not normal? But even this is sometimes really difficult to understand or to make a difference when someone has never seen it. So I think the next movie we can show you, this is a typical sudden cardiac arrest. And I think when you see it the first time, you think, no, it is not, because he is still moving and he is still breathing. And so this cannot be a sudden cardiac arrest. As you can see on the left side, the player is collapsing and he's going on his knees by himself. It was not like in the first movie when he was falling down. And now look at him. He's moving. He's moving around. He's breathing at this moment. So this is the first time. This is the first moment of a sudden cardiac arrest where he has a rapid ventricular tachycardia with a minimal output. But one thing is the player is not responsive. So this is already a phase where the player cannot give you any answers or react on what you're doing to him. Sometimes it might be also that the players have seizure, because of course we have a minimal flow at the beginning of the first moment, but then we have a no flow when it comes to ventricular fibrillation. They have no flow, so the oxygen in the brain gets down, and then you can have a seizure. So sometimes if someone is shaking, and I don't know if all the people already have seen how it looks like. But even these movements are not normal movements, and these are already a sign of a sudden cardiac arrest, because it's just a sign that the brain doesn't get any oxygen anymore.
Okay, so hopefully we've recognised the AED, the sudden cardiac arrest. What do we do next?
The most important thing is run on the pitch with your tools, with your equipment. Take the AED with you. If you don't, time is life in this case. So let's talk about, if you run on the pitch, you go to your player like you normally do, and then you suddenly recognize this is a sudden cardiac arrest, and then okay, I can help him. I can save his life by using the AED, and the AED is not with you. You will lose so much time, because this is a situation where everybody is very nervous and no one will follow your instructions. So you will lose the player by not having the AED with you. So every time you are suspicious of a sudden cardiac arrest, you need to take the AED with you. That's very important. It's also very important that you learn to follow a structured approach. We call it the megacode training, which will lead you step by step through the CPR. So one point is take position. The team leader is going with the AED at the head, and the assistant, or sometimes you have two assistants, they go to on the side of the player. Because what is the next step, what you have to do? You have to check, if you follow the guidelines, you have to check, is the player alive or not alive? And there are two signs. One is the player does not respond is unresponsive. So you can ask him something, or the best methods what we are using is give him pain, and he is not reacting on it. This is the first sign. The second sign is he breathing normal or not normal? And this is what I mentioned before, very difficult for someone who has never done it. If you look in the guidelines, they said check the breathing by looking, feeling, and listening. If someone is unconscious, that he cannot breathe normally, you have to do a chin lift or head tilt to have a free airway. And after this, you can check if he's breathing or not. But I would like to say, don't lose too much time doing it. So normally we can do it in 2 or 4 seconds. We have already the information. But if you have any doubt, just skip it and treat him as if it is a sudden cardiac arrest. While you're doing it, you or someone else, of course, should call for help. This is very important that you have, because you're a layman and you need professional assist. And so someone has to call the ambulances to help you.
I think even as a doctor, you need help, don't you? This is not something you're going to manage on your own.
No, this is also something what we noticed. We have the sudden cardiac arrest on the pitch, where not only one doctor is present, sometimes two team doctors are present. But the situation is like you're normally specialized in sport medicine and not in emergency medicine. So this whole situation might be very difficult and stressful for yourself. And we talk about the basic life support, which everybody can do. But after this, we have the advanced life support, and this is normally really something what professionals should do, is like the airway management with intubation, to give the medication you need for a sudden cardiac arrest and all this stuff. So, of course, you need professional help. So, when we check this, is the player alive or not? And what I said, in any case of doubt, is he alive or not? You treat him as if he is not. So what you have to do is you tell your assistant on the side, start with the chest compression, which is very easy. It's just in the center of the chest. You have to press down approximately 5 centimeters and with a high rate of 100 to 120 per minute. And this you should do really like this, otherwise it's worth nothing. So what we do is we create some spontaneous, we create circulation. And what we do is we transport oxygen from the lungs into the brain. And we are just doing it. This CPR should continue uninterrupted until the AED is applied and begins to analyze the SLS cardiac rhythm. So the most important thing is, while the assistant is doing the CPR, that we are the head, the guy with the AED is preparing the AED and plug the pads on the chest of the player. If we have done this, of course, then we cannot do the chest compression while the AED wants to do the analysis. So we have to step back and wait that the AED is doing his work. And so then if the analysis is done and the AED said it's shock advised, we will shock the patient. And after we shock the patient, then it's very important that we directly start with the chest compression again. So the reduction of the no-flow time is very important because we want to resuscitate the brain. And therefore, we need a circulation to transport the oxygen to the brain. So a successful resuscitation is be very quick with the AED. And if you do a chest compression, do it correctly.
So Jens, I've started a video here that I think graphically illustrates how effective an AED or a defibrillator can be. Can you talk us through what we're seeing here?
Yeah, there we can see it's a player who suffers from a sudden cardiac arrest. And now when you look at his legs, you saw already that he got shocked. And what happens if he got shocked that quick? Normally he stands up. This was a player from the Belgium league, is Van der Loo. He had an implemented ICD. And of course, we cannot be that quick, but this just demonstrates if we are quick with defibrillation, we save the life of the patients. If you do a defibrillation, yeah.
Perhaps I'll just the player has a non-contact collapse. We can see him fall over there.
Yeah, there you can see him collapsing. And now when you look, the best is you look at his legs, because there you can see the moment when he got shocked. There he was shocked. And then after, when you shock a heart, it's like a reset. It's like a computer. It started to boot again. And then after 10, 20 seconds, luckily he got his own spontaneous circulation back. So he survived. Also, if you do a defibrillation within 5 minutes, 75% return to a cardiac output. And each minute of delay to defibrillate reduces the survival to discharge by 10%. So we have to be very quick. This was shown in the first one of the first slides, where we talk about the 2 minutes. Try to defibrillate someone within 2 minutes after the eyewitness sudden cardiac arrest.
So as you mentioned, if the AED the shock is not successful, we start the CPR again.
Yeah. This is also very important. What I said at the beginning, also, we want to resuscitate the brain. So we need to bring oxygen into the brain. And this we only can do with the chest compression. So after we gave the shock, we directly start with 30 chest compressions again, with a rate of 100 to 120. And we don't wait for, if the AED was successful, the shock was successful or not. We start directly. This is also important to know for everybody. We will not harm anyone by doing a chest compression. Even if let's say we did a shock and the shock was successful, and we start, before we could see that it was successful, we start with chest compression. This will not harm the patient. It's not that we will bring him back to fibrillation by just doing chest compression. This is not. So the chest compression, we don't harm the patients, And what we do is, this is what I said, we bring the oxygen into the brain of the patients. And when we talk about oxygen, we also start, then we are in the rhythm, which you already know, most of you should know. It's a 30 chest compression followed by 2 rescue breaths. When we talk about the rescue breath, you have to know that the adult human body has a reserve volume of oxygen, which is called the residual volume of the lungs, which contains normally oxygen for at least 3 to 5 minutes before we are too short in it. So the rescue breath, we have time to start with it. So once at the beginning, what I said, we don't start with breathing, we just start with chest compression. We place the AED, and after this, when we have done this, after the first shock, then we can start with the rescue breath. The best for the rescue breath is not like shown on this picture, where I use a pocket mask. The best if we have an AMBU, or like an igel laryngeal mask, to give the air with an AMBU, because the environment air contains 21% oxygen, which is enough for a good resuscitation. And also studies show that even you don't need to give them high oxygen flow by a cylinder, because a neurological outcome seems to be worse if you breathe someone with 100% oxygen instead of 21%. So this is also somehow a good news, that the doctors don't have to carry around these heavy bags with the oxygen cylinder in it. So then we are in a rhythm which you already know when we are so far, that we started chest compression, rescue breath. This we do at least for 2 minutes. And normally the AEDs are programmed that they tell you then, okay, after 2 minutes, stop now. I want to check again the rhythm. So after 2 minutes, or if you don't, after 2 minutes, this is normally after 5 cycles of chest compression and breathing. You stop again. You don't touch the patient because the AD would like to analyze again the rhythm, and then we are in a, then we are at the beginning, or we are that the players has survived. So this is the AD can tell you, okay, I want to give another shock. Then you do the shock again. If the player or if the athletes start to move or any sign of life come back, of course, then you can stop it. And so this is the CPR should continue until return of spontaneous circulation is achieved, or, what is the worst case, if death is declared at the receiving facility. But this, of course, we don't want to see, and I can promise you, and this is a good thing, if we have an eyewitness sudden cardiac arrest on the pitch, if we have the tools, if we follow these regulations, so if we really also can use the AED for a diagnostic reason. So if we are not sure, is it a sudden cardiac arrest or not, use the AED, don't lose time. And if you shock him, you have seen it in the video, these people have a good chance of survival. So this is the message. So when I see it, I'm a little bit shocked when I see that we still have so many dead people on the pitch, where actually it can be so easy to save their lives.
Great. That's absolutely fantastic, Jens. Thanks very much for your time. We're not quite ready to finish, though, as there's some questions from the medical network. So for those of you out there listening, remember you do have the opportunity to pose questions to our experts via the network. And to do this, you need to join the 1111 group and post any relevant questions to the wall, and we'll do our best to answer your questions. The other thing I just want to highlight today is that the video clips we have shown you today have been sourced from the internet, and we'll share the references with you on the network. So Jens, let's get into the questions, some of which you've already answered. So when do we need to consider starting the rescue breathing?
So the rescue breathing is, okay, if you follow the guidelines, the first moment is after the first shock. After the first shock given by the AED, then we come to the rhythm, 30 chest compressions to rescue breathe. But what I said, normally an adult body has still a reserve volume of oxygen for at least 5 minutes. So within the first 5 minutes, we don't have to do it, but after 5 minutes, we should start with it.
Right. It seems to be a very muscular victim that you have there. Very handsome.
Yes.
The next question is, what emergency drugs do you think I should have in my sideline emergency bag? So I guess a lot of us are sport and exercise physicians, or we're orthopedic surgeons, and maybe if we're thinking about a training environment, do you think we should have the full complement of emergency medicine drugs, or what do you think we should be carrying with us as a minimum?
You're talking about now for sudden cardiac arrest or in general?
Sudden cardiac arrest we're talking about still.
Yeah, sudden cardiac arrest is very easy. There are only 2 medications in use anymore. So this now it's, of course, adrenaline. We have to have this. And the second is amiodarone, which is an antiarrhythmic medication, which you give after the third not successful shock.
As you say, that's pretty straightforward these days. And the final question is, what is the best type of airway to have in my sideline bag?
So the best type of airway, in my opinion, is a laryngeal mask. And when I talk a laryngeal mask, where there are several on the market, I would like that you order, if you use it, it's called iGel. It's a laryngeal mask where you don't have to inflate or whatever. You just put it in the mouth of the patients, and that's it. and then you use the ambu. Of course, as an emergency doctor, we are used to intubate, and we can do it easily. That's, of course, still the art to give the air, because then you also have protection for aspiration. But for all the others who are not doing it on a regular base, I highly would recommend to use the eye gel, because even a mask, if you will use an ambu with a mask, I think sometimes it might be difficult if you are not used to handle this. So, but the eye gel is really, everybody can use it. And then what I said it also during the presentation is, please, if possible, use an ambu, because with the ambu you can give the 21% oxygen, which is in the environment air. If you do it mouth by nose, if you have nothing else, that's good. But then you only give 19% of oxygen, because you give him your air, which you already use oxygen from. So this is also possible, but it's not the best solution.
Okay, and just to be clear, that's an ambu bag, and I'll post a link to the eye gel and an image of an ambu bag on the network, just if anyone's interested.
Yeah.
So Jens, thank you very much for your time. We very much appreciate you sharing your expertise with us, and hopefully we're trying to prevent the next sudden cardiac death.
I hope so too. Because, as an emergency doctor, it is so easy. It is really so easy to help these people when you know what you are doing and when you do it very quick.
So Jens, thank you very much.
Thank you, Mark. Thank you.